Good evening. Sorry we've started this late today. It's our Facebook live event. We're here. I'm Alison Campbell, Group Director of Embryology for Care Fertility, and this is Professor Charles Kingsland.
Good evening. I'd like to say we're late because Ali was having trouble with her makeup, but I can't. It was a technical issue, so I apologise as well. But here we are, and so hopefully we're around for the next half an hour so that we can answer questions and also enlighten you on our work, what we can do, and the treatments available if you find yourself in a position of having difficulty trying to achieve a pregnancy at a time in your life when you want to. So, should we just talk about infertility to start off with? And we define infertility as an inability to conceive after a year of trying with unprotected sexual intercourse. And the reason we choose a year is that if we took a group of couples of fertile years and we asked them to go away and try and get pregnant, over the course of a year, probably 70 to 75% would be successful. Now, if we left it for 2 years, that 75% would only go up to about 78. And then beyond that, the pregnancy rate really tapers off. So if you haven't achieved a pregnancy after 1 year, then there could be a problem. And at that point, we define we use the term infertility. If obviously couples are a little older, then the time span is a little bit shorter, and we may reduce it down to 6 months. But after a year, if you're trying to achieve a pregnancy and you're having difficulty, that's the time to probably seek medical advice.
Mm-hmm. Yeah, and there are many causes of infertility. We won't have time to go through all of those, but most commonly, and some people find this quite surprising, but most commonly it's male factor infertility. So there's an issue with the quality or quantity of the sperm.
The other 30-40% is due to female factors, the commonest ones being damage to the fallopian tubes or problems with releasing an egg from the ovary. And then there's a whole group of what we call unexplained infertility. We can't find a cause. It doesn't mean to say that there isn't a cause, it's just that no cause is apparent. But what we have to remember, and what Ali said, is that infertility is a disorder of couples, and we shouldn't just burden the responsibility to seek advice to the female, because 50% of the time it's the male.
Mm. Yep, we have many different treatments that we use to overcome infertility. And if we talk about male factor initially, then the most common and the most successful treatment would be ICSI. And we get a lot of questions because we want to talk about frequently asked questions this evening. And one of those would be, what is the difference between IVF and ICSI? Now, actually, ICSI, which stands for intracytoplasmic sperm injection, is a form of IVF, and IVF stands for in vitro fertilization. But when we're talking on a daily basis in the labs and with couples and patients, then IVF is referred to as conventional IVF. So it's simply where we mix the eggs and sperm together once they've been prepared. And ICSI, we only use a single sperm for each of the mature eggs. So we actually inject the sperm into each mature egg. And both are very successful treatments, but it depends on the situation that we're faced with as to which one we'll use.
So we've just got a question coming in now, is how is infertility diagnosed? So once we've established that a couple might have a fertility problem, the first port of call is usually the general practitioner. And he or she may be in a position to investigate a couple, or he or she may wish to refer the couple on to the local district general hospital, which in the Department of Gynecology there is usually a specialist in fertility. But irrespective of everything you read on the internet, on Google, there are only 3 questions that we need to know with regard to your fertility status. Number 1, and this is for the females, do I have eggs in my ovaries? Number 2, are all my bits in the right place? And number 3, do the sperm that are deposited in my vagina have the ability to swim to my egg? Bear in mind that for a sperm to swim from the vagina to the egg is the equivalent of a man swimming from Manchester, where we are now, to New York. It's at about 600 miles an hour. So it's hardly surprising when you think about it that a lot of problems lie with the male, and we were just talking then about ICSI and IVF treatment, which can be very effective. But to make the diagnosis then, have I got eggs in my ovaries? 2 common investigations are an ultrasound scan where you can look at the ovaries and do what we call an antral follicle count, which is to look at the number of follicles, which are the little fluid-filled sacs, which may be filled with eggs. So the more antral follicles you've got, the more eggs you've got. There's another test called AMH, anti-Mullerian hormone, which is a hormone that's secreted by the eggs themselves, or the little cells that surround the eggs. And that gives us an indication as to how many eggs you have. It doesn't tell you about the quality of the eggs, but it tells you about the quantity. And that can be quite effective and quite a useful indicator of fertility. And then we've got the standard pelvic ultrasound scan, which looks at the uterus, the cervix, and the fallopian tubes. And then what we can do is to inject a bit of bubbly dye through the cervix, which we can then scan and watch the fluid coming out through the uterus, through the fallopian tubes and into the pelvis. That gives an idea whether the fallopian tubes are open or closed. And as for the sperm count,
so as for the sperm count, we look down our microscopes, we measure the volume of the sample, and we can calculate how many motile sperm is the most important thing there are in that sample. We'll also look at the shape of the sperm, so the shape of the head in particular. There's a mid-piece and the tail, so we can measure the proportions and diameter of these sperm, so we know if they're normal, and if they are normal shape, then they have more chance of fertilising the egg than if they're an abnormal form. And actually, what we're looking for is at least 5% normal forms, and it sounds really low, but that's actually all we need to say there's no great issue with the sperm morphology. So it's very, very common to see all sorts of shapes and sizes when we're looking down the microscope at a sample of semen.
So if we do discover a male with a low sperm count, are there any things that we can do to improve the quality of sperm?
Yeah, well, we would always recommend healthy diet and lifestyle. We've seen studies that show if the temperature down below is too high, that's really not good for sperm, so hot baths should be avoided, tight underwear. And there are supplements that can be taken to give the right vitamin balance and improve sperm quality.
I think the key is with any situation like that is healthy lifestyle. There is no doubt that being overweight, eating the wrong foods, smoking or drinking alcohol to excess can have a detrimental effect on sperm. Similarly, a lot of the drugs that we take, there are some medications that GP might prescribe that can be detrimental to sperm, but the classic one that we find nowadays, particularly amongst young men, particularly amongst fit and healthy young men, are protein supplements, and in particular steroid supplements that a lot of healthy, fit, active men will take to enhance their gym performance or their athletic performance. Now, steroids can have a very positive effect on athletic performance, but similarly they have a very negative effect on testicular and sperm performance. So a balance has to be taken. I've often seen in my clinic a lot of very healthy, very muscular athletic males who are strong and fit, but they have low sperm counts because of taking too much steroid to enhance their performance, and also things like protein drinks. Some protein drinks, the poorer quality ones, can have traces of elements that can be detrimental to sperm. So, is there anything we can do to improve egg quality?
Well, it's the same sort of situation. We would always recommend healthy lifestyle as well for the women. And again, no smoking, minimal alcohol, lots of activity, running, exercise, balanced diet. So it depends really on the cause of the egg quality. It can be hormonal, and we may be able to do not much about that. We could see premature ovarian failure, meaning that the woman has reached menopause early or is on the way there, so egg quality will decline, and there's not really much we can do to reverse that. So it's a difficult one. So it very much depends on the individual circumstances, but always healthy lifestyle if you're trying to conceive or considering conceiving in the near future.
There's a question here. Why does fertility decline so rapidly? The way I usually describe this is the difference between males and females is that males are sperm factories. We have all the ingredients in our bodies to make sperm every day of the week. Some days we're good at it, some days we're bad at it. But it takes us about 6 weeks to make a sperm. We store them for a short amount of time, release them, and make some more. But we theoretically have got the ability to reproduce up until the day we die. The sperm quality does decline as you get older, but also our performance, and we just lose interest in putting sperm where it needs to go when we get older. Other things take place like golf, sky sports,
gardening,
being mates. That's a bit different to women. Women are egg warehouses, so a woman has a full complement of eggs on the day she's born. Actually, on the day she's born, she's already started to lose eggs. Women cannot make eggs, they cannot make them better, they only get worse, and they're stored in your ovaries, and then as you get older, they are released, and that is why a woman's fertility declines much more rapidly than a male's. In fact, a woman's fertility declines very rapidly over the age of 35, and it drops like a stone over the age of 40. So age has a very significant effect on a female's fertility. Of course, it helps if you're born with a lot of eggs, but if you're not, then your fertility can run out much earlier than you think. And it's important that women should recognise that. When we're younger, we're always concerned about preventing fertility. But also we should bear in mind that preserving fertility is also very important. Smoking, very detrimental effect on egg quality. Drinking large amounts of alcohol, being overweight, eating the wrong foods. These can all have a detrimental effect on egg quality, and you cannot improve egg quality. Getting older is the key one, but irrespective of what health food shops may say or what you read online, you cannot make eggs better. You can improve your fertility by getting your weight to an appropriate level, or just enhancing your diet with vitamins and minerals, or better still, eating them as part of a good quality diet. But there is little in the way of medication that can improve the quality, and sometimes it can be quite misleading. That I see couples who come to my clinic where the female is over 40, and they're on a whole plethora of medications that they bought on the internet or bought at health food shops in the mistaken belief that this is going to help them. It's not harmful, most of them are not harmful, but you have to be realistic about what is beneficial and what isn't beneficial.
So would you recommend a young woman to freeze her eggs to preserve her fertility?
Well, that's an interesting question, Alison, and if you asked me that 10 years ago, the answer would have been no, I wouldn't. But because we just didn't have the reliable technology, and you'll know that about freezing eggs. Nowadays, freezing of eggs is much more successful. We've always been able to freeze sperm and thaw it out very well. And for the past 40 years, we've been able to do the same with embryos. But eggs are very, very fragile. A human egg is actually smaller than a hamster egg. And the problem that we've had is that, and I'm not the expert on this, but I'll carry on, you can correct me when I make a mistake, is that eggs are so small, and when we used to freeze them in liquid nitrogen, they'd crack or they wouldn't thaw properly.
Well, this is because of the high water content, and with traditional freezing, we get ice crystals, which you've probably seen. You can imagine when you see the freezing on the window pane, they're quite spiky and sharp. You see this ferning, and that would damage the membrane and cause the cells to just be disrupted and lies to break. So with the newer methods called vitrification, we use completely different system. So the water is removed and replaced with a solution that vitrifies. It forms some sort of glass-like state, a very smooth. So there's much less harm, much less risk of cell damage. And when we freeze eggs this way, more than 85% will survive. So it's phenomenal, really, the survival rate. And with embryos, more than 99% of them survive. And the pregnancy rates are equivalent to fresh. So it's quite remarkable the way, and that's changed it during my career. In the last 5-10 years, it's changed dramatically.
Yeah, I'm actually quite surprised that what so-called social egg freezing is not as popular as it could be, because it really is nowadays a very, very useful insurance method of preserving your fertility, particularly if you don't want to settle down, or you haven't found Mr. Right, or your career is progressing very well and you want to delay your family into your mid to late 30s, for example, and that's fine. What you have to bear in mind, though, that biology catches up very quickly, and irrespective of how healthy lifestyle you have, your fertility will inevitably decline as you get older. Having eggs frozen in the bank at an early age could theoretically preserve your fertility. So, say for example, at the age of 40, you think that the time is now right for you to have a child or settle down and have a family. It may be that your natural fertility has declined quite substantially, so that if you have got eggs in a bank that you froze when you were in your early 20s, for example, you can go to them, thaw them out, fertilise them with the sperm of the man of your dreams, which you've now found later in life, create that embryo and replace it into your uterus, obviously in a dedicated fertility unit, and the results are pretty impressive, aren't they?
They are remarkable. Yeah. So we need to move on to the next topic. Should we talk about genetic testing? So the difference between PGS and PGD. So PGS, it's now the terminology's all changed. PGS and PGD were the old terms, but both of these techniques are now PGT, pre-implantation genetic testing. And we can either do testing for aneuploidy, which is when the chromosome number is wrong. We've got either an extra one or a missing chromosome, and the risk of this increases with age. Or we can do pre-implantation genetic testing for monogenic, for genetic disorders. So that's probably a lot of jargon, but how we would do this in the embryology laboratory would be to take a few cells from the developing embryo and get those tested. And so we can send them to the genetics lab, and they'll let us know whether the sample of cells that we've removed very carefully from the embryo, from the blastocyst, indicates whether that blastocyst, that embryo, has the right number of chromosomes, or is not carrying the genetic disorder we're looking for, or not. So that was also it's been improving over the last 10 years or so, and a very effective treatment option for patients.
Yeah, it's becoming a really impressive option for couples who have had failed IVF, or whose embryos have just not developed as well as they could have done. It's certainly something that I've become more aware of in my practice over the last 4 to 5 years. Obviously, when you introduce a new technique, there's a period of doubt. You need to get the evidence to see whether it's of unequivocal benefit, but then it starts creeping into clinical practice, and at that point, it's important though that you should recognise when it is useful and when it may not be useful, and you can only do that if you've had some really expert informed advice, and then you can make your decision as to whether it's right for you or not. Which actually leads into the next question. I've had 2 failed IVF treatments and 2 miscarriages. What treatment is available for me? Well, this lady, I'm sorry, I don't know who you are, but there are different circumstances for different patients, and it's very difficult to generalise the sort of question, generalise an answer for this particular question. But there are some very important factors. Firstly, the age of the patient. Secondly, your ovarian reserve. What is your AMH? What is your antral follicle count? Do you have good quality eggs? Do you have poor quality eggs? Do you have lots, or do you have very few eggs? What was the fertilisation rate in the IVF? How many of your eggs fertilised? Did you need IVF? Did you need ICSI? And why was it that, presumably when you had your embryos replaced, why was it that embryo resulted in a pregnancy which ultimately failed? And it's a disaster for the couple when they go through all the heartbreak of the diagnosis of infertility, then all the turmoil and the emotional turmoil of the treatment, only for it to succeed for a short-lived period of time and then fail. Losing a pregnancy is a very emotional and traumatic experience, and it's important that couples grieve properly over that baby that they've never seen. But once that has been done and you feel as though you can move on, it would be of use to find out why you miscarried. What was the cause of that? Now, I know generically that the commonest cause is fetal abnormality. Most pregnancies that are lost in the first 12 weeks of pregnancy are due to fetal abnormality. And we have this strange description that we lose a baby. Oh, I've lost the baby, as if there's this tiny, well-formed baby hanging on in the uterus by its fingertips saying, please, mummy, don't let me fall out. And there's a degree of guilt that's associated with that. Well, actually, nothing could be further from the truth. What's happening is 99 times out of 100, it's a healthy uterus expelling what was going to be a non-viable pregnancy. Now, there are causes of recurrent miscarriage where a woman will miscarry on 3 or more occasions, which should be investigated. Are there different anomalies? Is there a uterine abnormality? Are there blood clotting factors that could have caused the miscarriage? Are there blood clots forming behind the afterbirth? Or are there antibodies within the female's blood circulation that are rejecting the babies? But a very useful investigation that you can do to see whether those embryos are abnormal is PGT.
Yeah, that's right. Yeah, so you say these early miscarriages, they're often due to chromosomal abnormalities in that the copy number of chromosomes is incorrect. Not many aneuploid conditions are viable. We know of a few, of course, Down syndrome, where there's an extra chromosome 21. But if there was an extra chromosome number 5, for example, or 10, then these are not compatible with life. So this is why we see these early miscarriages.
And what about PGT2? What's the technique? What do, if couples need that treatment?
Well, they have to go through an IVF procedure. So we have to do the whole. We haven't really talked about what that entails, but we stimulate the ovaries, so we collect a good number of eggs, and this would, on average, be 8 to 10 eggs. We'll use the sperm, we prepare the sperm, and we'll create embryos either by IVF or ICSI. We've talked briefly about those two techniques. Then we'll culture those embryos in the incubators, perfect conditions, matched as closely as we can to physiological conditions in the body. And then at this blastocyst stage that we mentioned, we take a few cells from the blastocyst, from the embryo, and they'll go off for testing. So it takes about 2 weeks then to get the results back, and then we'll know which of the embryos from that cohort, from that group, have the right copy number, are the normal embryos in inverted commas. So they're the ones that we focus on. They're the ones that we'll transfer, because they go through the vitrification process. They'll be frozen, and then we'll transfer a single normal copy number embryo. And the pregnancy rates with this technique are really, really good, really high.
So that's some encouraging news. The final question for this evening, and it happens to be an embryological one, so I'll read it out and you answer it. What is time-lapse imaging in IVF?
In a nutshell. So we've talked about PGTA, so we've talked about embryo biopsy to help us choose the best embryo. And it's an invasive method, it's highly effective. But there's another method which is non-invasive. It's because PGTA is not for everybody. It's not indicated necessarily for every patient. But time-lapse is a very relatively simple, non-invasive method to help the embryologist choose the best embryo. So if you can imagine, we have standard incubators where the culture dish, I saw one out of the corner of my eye, I'll grab one. Here we are. So a little Petri dish like this, not dissimilar to this. So we'll have the embryos in this dish in an incubator for routine IVF. And every day the embryologist will take this dish out, look down the microscope, here's one behind me, and have a look and see how the embryos are developing. Well, with time-lapse imaging, which is a phenomenal introduction over about the last 10 years or so in IVF, the embryos sit inside a specialised incubator and photographs are taken every 5 or 10 minutes through several focal planes, so we can construct a really detailed video of how the embryos are developing without taking them out of the incubator. So it's completely undisturbed, controlled environment, and we're gathering lots of information. So the embryologist can use that information to make sure they choose the best embryo the first time. So this has also improved pregnancy chances for couples over recent years. So yeah, another great introduction to IVF and to our toolbox.
Great. Well, it's a little bit, time is drawing on, and it's time for us to wrap up. Now, this was the second of our programmes. The first one, we got some very good feedback, so we would welcome feedback from you now. We hope to do it again in the not too distant future, maybe the next month. Apologies again for us being late due to a technical difficulty, but we got there eventually, and thanks for staying with us, and we'll see you again soon. Thank you.
Thank you.